trimester.
Ah, okay. So see, today you get variety of USG machines. Any machine which has a color Doppler, right, means a certain level of B mode resolution is available.
Yes.
Okay. Now we don't go by the size of the machine because technology has developed so much. We have small machines giving you extraordinary image quality, and we also have very big machines with all 3D, 4D, everything is there. But uh, a- an, an intermediate level machine should be more than sufficient to do most of your work which is there. You don't need to go for very high-end machines at all. Very high-end machines must be used by experts who are willing, who are doing that as a full-time job and putting a lot of effort and trying to do very high-end work with higher frequency transducers and other things. So a mid-range machine should be more than sufficient. Now with a there are portable machines which are available today, which will do most of your 80 to 90% of your work too. And so all you need to see is you need to see in a patient whether there's good penetration, and once you see the, let's say if you take the image of the heart, lot of internal echoes and other noise which comes in the image, and the frame rate of the machine is very good. That is, when the heart is beating, you should not see the heart beating very slowly. So once you have a good frame rate and good contrast, that should be do. In fact, there are very few bad machines in the market, and that too, that's a very low end, very portable, where you can use it only in the labor ward for looking at fetal heart and placental position and these things. But most of your machines will do your job.
Right, right. Sir. So you can now stop sharing your screen so you can see many of us on the screen.
Yes, yes, correct. Yes.
Yeah. So next is how can we diagnose micrognathia?
So micrognathia, as I said, you take the mid-sagittal view of the face, right? Then your mandible. I think that's why I should probably show that. Let me just share the
Yeah, yes,
screen
sir. Please,
once
sir,
more.
please. Yes, yes, sir. Please.
1 minute.
Yes, sir. Yes, sir. Please try.
Okay, because that mid-sagittal view will show. Okay, so go to the end. Face. Yes. So now you can see this mid-sagittal view. So this is your maxilla. Okay, this is your upper lip. Now right below the maxilla, you should see the mandible. Here the mandible has gone behind. So it has gone behind. So you should see the white dot coming here. So that should give you the diagnosis. The mouth has gone back. You can see the chin has receded back. The mandibular dot is here. So this is micrognathia. So if you go to the normal thing which I showed you, so this I put the mid-sagittal view of the face. That's right. Okay, sorry about that. So in this mid-sagittal view of the face, you can see the upper lip and the lower lip coming together, and you should be able to see the upper lip and lower lip in the same position. Then you're all right. Yeah. Next question.
Yes, sir. What is the normal range for kidney pelvic dilatation in second trimester?
Okay.
That's what I
So
think.
second trimester, see less than 4 millimeters, you don't need to worry at all. 4 to 7 millimeters in the second trimester is all right. Anything more than 7 millimeters in the second trimester, we consider it as abnormal.
Right. Sir, Dr. Deepshika wants to know where we can get to know the details about your online classes if you are conducting any.
Well, we've done quite a few now because it all comes to the WhatsApp circulation. There is also, we have now made a sort of a, maybe I'll share that with you. We have created an application where I'm trying to put as many webinars into that as possible as a webinar calendar. So
Oh,
you can go there and see that because I find too many webinars are happening. People don't know what's happening when.
correct.
So this is a webinar calendar according to the obstetrics and gynecology separately. Put that, you will see all the webinars that are happening there. So I'll try to share that with you. It was developed just the last week.
All
We'll try
right,
to
sir.
share that with you. Yeah.
Yes, sir. I forgot to tell you that we had a houseful session today, and we had 1,000 participants logged in. So I'm so glad I upgraded the plan today. So can callosal agenesis be missed in the targeted scan?
Excellent question. Before I answer that question, I'll also have to today welcome to a lot of participants from Philippines.
Yes, a lot of them.
So that's a welcome to all of them, and so I hope all of you are safe. So what was the question?
Corpus callosum.
Corpus callosum.
Yeah.
Now remember the corpus callosum development is happening through the second trimester, and the development is completed by about 20 weeks or so, right? So most of the time, around 18 weeks, between 18 and 20 weeks, you should be able to see the cavum septum pellucidum. When the cavum septum pellucidum is absent, then you need to do a mid-sagittal view to identify the corpus callosum or show whether it is complete or incomplete as that. Now, there are cases, supposing you do the targeted scan at 18 weeks, sometimes the development may not be complete and it can get missed. So you have to be careful. And that time, so when you do the lateral ventricle, the dilatation of the lateral ventricle also may not be significant.
Correct.
It may be just around 9 millimeter or 10 millimeter, but the frontal horn will look very pinched. So corpus callosum diagnosis can be missed at 18 to 20 weeks, but with very careful imaging, closer to 20 weeks, most of it you'll be able to find out. The
Correct.
partial ones may be difficult to find out. Yeah.
Yes. Should nasal bone length be measured, and what is the inference if it is small?
Yes. Good question again.
Yes.
Now, the first question I'm going to ask is, did this patient have a first trimester scan, first trimester screening? If they've had a first trimester screening for Down syndrome and nasal bone is already measured and already accounted for, presence or absence of the nasal bone are accounted for, then you don't need to consider it in the second trimester at all. This nasal bone in the second trimester is only if you have not done first trimester screening. Okay, because your nasal bone is a marker, it has already been used. Any marker is a filter. That filter has already been used in the first trimester.
Right.
You can't take the same filter and put it back again.
Right.
Right. So if it is not, if you know first trimester screening is done, if it is the second trimester and you're doing a second trimester screening, then using one of the genetic sonogram and nasal bone is one of the markers, then certainly measuring of the nasal bone less than 5th centile is considered as a marker.
So when will you call a nasal bone hypoplastic?
Less than 5th centile.
Yes,
There is Pratima has published the nasal bone data for Indian patients. So nasal bone less than 5th centile for the period of gestation is considered abnormal.
Right. What is the medical level responsibility of the doctor while interpreting the USG report to the patient or to the relative? Dr. Navneeta Dhanalakshmi wants to know.
Correct. When you say doctor, is it the doctor who did the scan,
Yes,
or the doctor whose observation was relating the report? Who's the
Dr.
one?
Navneeta, you need to spell
So-
that out. What do you want to know?
Yeah.
She's just
Because-
mentioned the doctor.
Let's tell for both. Okay, let's tell for both to make it easier.
Yeah. Yeah.
So for the person who has done the scan,
Mhm.
holds the primary responsibility
Correct.
for the report. because they have signed on the report, they own the primary responsibility for the report. The obstetrician who is explaining the report is based on the report which is given. It's like a blood sugar test which you do in a lab, and you read the blood sugar test. Let's say blood sugar is 400, and then the doctor panics and then put the patient in the bed, and next day morning they look at the blood sugar is 90, right? And they said, well, the lab report was wrong. So the doctor cannot be blamed for admitting the patient because she went by the report which was given to her. So the report, the counseling by the clinician is based on the report given by someone who has done the scan. The primary person holds the responsibility.
Yes. So please tell us the artifacts in amniotic fluid. What is the significance?
The artifact in the amniotic fluid.
Yeah.
Uh, the artifact in the amniotic fluid, there are many. One the most common one that you'll see is internal echoes, which can come in the anterior part. I don't think I have a picture for that. If the placenta is posterior and you do a scan, you see these lines which are coming here.
Yeah.
These lines are reverberation artifacts. Okay. Sometimes they can be so intense that they can look like a placenta. And they have been mistaken for a placenta. When the placenta was posterior, actually people have reported on anterior placenta. Similarly, the placental edge is here, but they have thought the placental edge is somewhere here. So that also can happen.
Right. So vertical diameter 10 mm at 28 to 29 weeks, and repeat scan shows 12 mm after 2 weeks. What to do? How to explain? What is the next step?
This is the amniotic fluid, isn't it? Amniotic fluid, deepest pool they're saying, right?
Yeah.
Okay. So once you say 10 mm, it's borderline high, and then it's increased to 12 mm, there is polyhydramnios. So 29 weeks, 12 single deepest pool vertical is 12 mm. So simple things I will do. I'll first check whether a detailed targeted scan has been done and all structures documented, we are fine. Second thing is, I look at, first of all, mother, I exclude diabetes. Second, I will look at the upper tract. Then I will look at the stomach. If the stomach is well good in size, then I am very reassured. If the stomach is very small in size, maybe there is a tracheoesophageal fistula or upper tract obstruction, which I'll look at. I will also go beyond and say, remember, any unexplained polyhydramnios, you must always do fetal middle cerebral artery Doppler. Now, why am I saying that? Is fetal middle cerebral artery Doppler peak systolic value